called it medicine. They called it progress. What unfolded on plantations, in improvised clinics, and behind the locked doors of Southern medical schools were medical experiments that redefined pain for enslaved bodies, and in doing so, redefined whose suffering counted as human at all. This documentary is about how 19th century American medicine learned to ignore the screams of the enslaved, how pain itself was reclassified along racial lines, and how those decisions were quietly carried forward as scientific fact. In the early decades of the United States, medicine was not yet a regulated profession. Authority came not from law or oversight, but from reputation, patronage, and results. Physicians were often self-taught, apprenticed, or trained briefly in Europe. What united them was not a code of ethics, but ambition. The South, with its vast enslaved population, offered something no medical journal could provide. It offered bodies that could not refuse. Enslaved people were property under law, but they were also valuable. Their labor was insured, mortgaged, and counted. This created a particular contradiction. Owners demanded that physicians preserve enslaved bodies enough to work, but allowed those same physicians wide latitude to experiment so long as productivity eventually resumed. Pain was tolerated. Injury was negotiable. Death was an acceptable loss if framed as unavoidable. Medical journals of the period spoke openly of this access. Physicians wrote of cases rather than people. They described conditions, unique to the Negro Constitution, a phrase that would harden into doctrine. Pain thresholds, nerve sensitivity, healing speed, resistance to infection, all were discussed as racial traits rather than individual variation. No measurement supported these claims. Repetition alone gave them authority. One of the earliest and most persistent beliefs was that enslaved Africans felt less pain than Europeans. This assertion did not arise from observation. It arose from necessity. A system that depended on forced labor could not afford to recognize full human suffering. Medicine, rather than challenging this assumption, refined it. Surgical procedures in the early 19th century were brutal for everyone. Anesthesia did not yet exist. Speed was the surgeon's virtue. Patients were restrained. Alcohol, if available, dulled awareness but did not erase pain. Yet white patients were at least considered capable of suffering beyond endurance. Enslaved patients were not. Plantation surgeons often performed repeated procedures on the same individuals: hernia repairs, bone settings, amputations, gynecological surgeries. When enslaved women cried out or resisted, this was noted not as pain, but as temperament. Medical notes described them as uncooperative, excitable, or unusually expressive. The assumption remained intact. If pain was expressed, it was exaggerated. The most infamous experiments took place in the field of gynecology, though they were not unique there. Enslaved women with chronic conditions were subjected to multiple invasive surgeries, sometimes dozens, without anesthesia. Their names occasionally appear in letters and memoirs, often misspelled, often without surnames. Their pain is described as a problem to be managed, not an experience to be respected. Physicians justified this by claiming future benefit. These women, they wrote, were helping science. Their suffering would spare others. Yet those others were implicitly white. The benefits rarely returned to the enslaved population. Techniques perfected on black bodies were introduced to white patients with care, caution, and eventually anesthesia. Pain in this context became a tool. If an enslaved person endured a procedure without visible collapse, this was recorded as evidence of lesser sensitivity. If they screamed, thrashed, or fainted, this was recorded as emotional instability. Either outcome reinforced the same conclusion. Medical education depended on this logic. Southern medical schools required cadavers. Laws restricted grave robbing of white bodies. Enslaved bodies filled the gap. After death, whether from disease, punishment, or neglect, bodies were sold or donated to anatomy labs. Consent was not considered. Families were not notified. Dissection was routine. Students learned anatomy by cutting into people whose lives had been controlled in every other respect. This physical dominance shaped professional identity. The physician was taught from the beginning that some bodies were meant to be opened, examined, altered, and discarded without moral consequence. Pain was further abstracted through measurement. Physicians tested responses to heat, pressure, and injury. They pricked skin, applied chemicals, induced burns, and recorded reactions. These tests were not standardized. They varied by physician, by plantation, by convenience, yet their conclusions were published as universal truths. One widely circulated claim was that enslaved people healed faster. This belief allowed for more aggressive procedures. If wounds closed quickly, then harm was temporary. If scars formed, they were dismissed as superficial. The long-term effects, infection, chronic pain, disability, were rarely followed up. Once an enslaved person returned to work, the case was considered resolved. When procedures failed, blame shifted easily. Failure was attributed to racial weakness, moral deficiency, or non-compliance. The physician's authority remained intact. The system allowed no other outcome. This medical worldview did not exist in isolation. It was reinforced by religious teachings that framed suffering as divinely ordained, by economic structures that demanded maximum output, by legal systems that denied testimony from the enslaved. Together, they created a closed loop. Pain existed, but it had no official voice. Occasionally, cracks appeared. Some physicians noted inconsistencies. They observed that enslaved patients reacted to pain much like anyone else. They questioned the assumption of lesser sensitivity. These doubts rarely reached print. Challenging racial doctrine risked professional isolation. Silence was safer. By the mid-19th century, anesthesia began to change surgery for white patients. Ether and chloroform offered relief from agony. Their adoption was celebrated as a triumph of modern medicine. Yet their use on enslaved patients lagged behind. Some physicians argued it was unnecessary. Others claimed it interfered with observation. A few worried it would encourage resistance. The disparity was not accidental. It reflected a hierarchy of care. Relief from pain was a privilege, not a right. Enslaved bodies remained experimental, even as standards improved elsewhere. These practices left records, but the records are partial. Medical journals preserved successes. Failures disappeared. Enslaved voices were filtered through the language of their captors. What remains is an archive shaped by power. After emancipation, many of these physicians continued their careers. Their techniques were praised, their textbooks reprinted. The racial assumptions underlying their work were rarely questioned. Pain thresholds attributed to race persisted into the 20th century, influencing diagnosis, treatment, and trust. Even as medicine professionalized, standardized, and regulated, its foundations remained uneven. The knowledge extracted without consent was absorbed without acknowledgement. The suffering that produced it was framed as unfortunate but necessary. This is not a story of individual cruelty alone. It is a story of systems that rewarded indifference, of institutions that converted human pain into professional advancement, of a society that allowed science to mirror its moral failures. The enslaved were denied the authority to define their own suffering. Their pain was observed, catalogued, and dismissed. In redefining pain for enslaved bodies, American medicine also redefined responsibility. It taught itself to look without seeing. The legacy of these practices does not end neatly. It lingers in mistrust, in disparities, in the quiet knowledge that medicine once learned to ignore certain voices. Understanding this history requires restraint. It does not offer redemption. It offers recognition. At this point, the record grows thinner. Names fade. Procedures blur together. What remains is the structure, the hierarchy, the belief that some pain matters less. The story continues forward from here, not with resolution, but with consequence. What followed emancipation did not undo what had been learned. Instead, it absorbed it. When the legal status of enslaved people changed, the medical theories built upon their bodies did not vanish. They were already embedded in textbooks, lectures, and professional assumptions. The end of slavery removed access to coerced experimentation on the same scale. But it did not remove the belief that black bodies were fundamentally different. Pain, once redefined, remained reclassified. Formerly enslaved people entered a medical system that had never been built to serve them as patients. Hospitals were segregated. Clinics were underfunded. Physicians trained in the antebellum period carried their habits forward. When black patients reported pain, they were often disbelieved. When they resisted procedures, it was interpreted as noncompliance rather than fear. Medical case notes from the late 19th century reveal continuity rather than rupture. Physicians still describe black patients as having remarkable tolerance. Surgical risks were downplayed. Analgesia was inconsistently offered. The language had softened, but the hierarchy endured. The authority of science made this persistence difficult to challenge. By the time professional ethics codes began to form, the foundational studies were already treated as historical fact. Few questioned how that knowledge had been acquired. Fewer still questioned whose suffering had been excluded from consideration. In medical schools, the stories were simplified. Innovations were attributed to brilliance and perseverance. The experimental subjects were reduced to anonymity. Their lack of consent was reframed as circumstance. Their pain was treated as incidental. This silence was not accidental. Acknowledging the full truth would have required confronting not only individual physicians, but an entire profession's complicity. It would have required admitting that progress had been purchased with coerced suffering, that medicine, like law and commerce, had adapted itself to slavery rather than resisting it. Instead, the profession moved forward, carrying its assumptions quietly. Pain assessment, a fundamental aspect of care, remained subjective. Physicians relied on patient reports, but trust was unevenly distributed. Studies well into the 20th century showed that black patients were less likely to receive adequate pain relief. These disparities were often explained away as cultural differences or communication issues rather than as the legacy of historical belief. The roots of those beliefs can be traced directly to the 19th century, when pain was racialized to justify experimentation. When enslaved people were declared less sensitive, it absolved practitioners of guilt. When that declaration became scientific doctrine, it gained endurance. There were moments of resistance. Black physicians, emerging from newly established medical schools, challenged prevailing assumptions. They documented pain. They argued for equal treatment. Their voices, however, were marginalized within a profession still dominated by those trained under earlier systems. The archival record preserves some of these challenges, but they are often buried in obscure journals or institutional reports. They did not reshape the mainstream narrative. The weight of tradition proved heavier. What is most striking is how rarely the original experiments were revisited with ethical scrutiny. Unlike other historical abuses, they were not widely condemned. They were simply forgotten. The absence of formal reckoning allowed the knowledge to persist without accountability. In this way, the redefinition of pain became self-sustaining. Each generation inherited the assumptions of the last, rarely questioning their origin. The enslaved bodies that had been cut, burned, and measured were no longer present, but their imposed characteristics remained. This is the quiet power of institutional memory. It does not require malice to function, it requires only continuity. When pain is minimized, care becomes conditional. When suffering is doubted, treatment is delayed. These outcomes are not dramatic, they do not announce themselves. They accumulate, case by case, reinforcing disparities that appear natural rather than constructed. The history of medical experimentation on enslaved bodies is often told as a closed chapter, confined to a brutal past, yet its influence extends forward, shaping how pain is interpreted, whose voices are believed, and whose bodies are still treated as resilient by default. The enslaved were forced into the role of experimental subjects, not because of unique biological traits, but because power allowed it. Medicine adapted itself to that power. In doing so, it altered its own moral compass. There is no single document that marks this shift, no declaration that pain had been redefined. It happened gradually, through repetition, through publication, through silence, each procedure performed without anesthesia, each observation recorded without empathy, contributed to a body of knowledge stripped of accountability. Understanding this history requires restraint. It resists sensationalism. The horror lies not in isolated acts, but in their normalization, in the calm handwriting of physicians who believed themselves to be advancing science, even as they erased the humanity of those they studied. The enslaved left few written records of their own suffering. What survives is mediated, translated into clinical language. Their pain appears as data points, not as testimony. Yet absence itself speaks. It tells us whose voices were never invited to define reality. As the narrative moves closer to the present, the line between past and present becomes less distinct. The assumptions forged under slavery did not remain there. They traveled forward, embedded in practice, influencing outcomes long after their origin was obscured. At this stage, the story does not resolve. It narrows. It asks what it means to inherit knowledge shaped by coercion. What responsibility exists when progress is inseparable from harm? These questions do not yield simple answers. The record grows quieter here, not because the consequences ended, but because they became ordinary. We pause at this point, not to conclude, but to acknowledge the weight of what has been carried forward. Ordinariness is often where the deepest harm settles. When assumptions become routine, they no longer require defense, they simply operate. By the late 19th and early 20th centuries, American medicine had begun to present itself as neutral, objective, and progressive. Laboratories replaced plantations. White coats replaced overseers. Yet the underlying logic that had governed earlier experimentation remained largely intact. The idea that pain could be interpreted differently depending on the body experiencing it had been normalized. Medical manuals from this period continued to reference racial difference as clinical fact. These references were no longer framed as experimental hypotheses. They were presented as settled knowledge. Black patients were described as stoic, less demonstrative, or naturally enduring. Each descriptor carried a quiet implication. Suffering need not be addressed with urgency. Hospitals serving black communities were often training grounds for young physicians. Resources were limited. Oversight was minimal. These spaces became modern echoes of earlier medical environments, where experimentation occurred under the guise of necessity. Treatments were tried, adjusted, and abandoned with little documentation. Failure was rarely traced back to systemic neglect. Pain management, still imperfect even for white patients, remained especially inconsistent for black patients. Morphine and other analgesics were tightly controlled. Decisions about dosage relied heavily on physician judgment. That judgment, shaped by inherited beliefs, often underestimated need. What had once been explicit coercion became implicit dismissal. The enslaved body was no longer legally owned, but it remained conceptually available. Available for risk, available for uncertainty, available for being wrong about. This continuity can be seen most clearly in moments of crisis. During epidemics, black communities were often subjected to aggressive interventions. Quarantines were enforced unevenly. Experimental treatments were administered without full explanation. Consent, while now theoretically required, was frequently reduced to formality. Physicians justified these actions by appealing to public health. The language was different, but the power dynamic was familiar. When outcomes were poor, explanations echoed older patterns: biological difference, environmental weakness, cultural misunderstanding. Rarely did the system examine its own assumptions. The absence of reckoning was not due to lack of evidence. It was due to selective memory. Medical history celebrated innovation while quietly discarding context. The suffering that enabled discovery was treated as background noise, unworthy of sustained attention. This selective memory shaped professional identity. Physicians were taught to see themselves as heirs to progress, not as inheritors of moral debt. The experimental past was reframed as a necessary stage in development, rather than as a cautionary tale. As a result, ethical guidelines, when they emerged, often addressed consent in abstract terms. They focused on procedure rather than power. They did not fully account for how history influences trust, perception, and vulnerability. For black patients, this gap was tangible. Encounters with medical institutions carried an unspoken weight. Stories passed down through families, of neglect, of pain dismissed, of bodies used without permission. These stories rarely entered official discourse, but they shaped behavior nonetheless. Mistrust was often pathologized. Physicians described it as irrational fear or lack of education. Rarely was it recognized as historical memory. The medical system expected trust without acknowledging the reasons it had been broken. This dynamic reinforced itself. When patients hesitated, care was delayed. When care was delayed, outcomes worsened. Poor outcomes were then cited as evidence of inherent vulnerability rather than systemic failure. The cycle continued. The redefinition of pain had long-term consequences beyond medicine. It influenced labor practices, insurance assessments, and legal judgments. Injuries suffered by black workers were often minimized. Disability claims were denied or undervalued. Testimony about suffering was weighed differently depending on who spoke. Pain, once racialized, became a social currency distributed unevenly. Even as civil rights movements challenged overt discrimination, subtler forms persisted. Medical language adapted. Explicit references to racial pain thresholds became less common, but the assumptions remained embedded in practice. They surfaced in split-second decisions, in triage priorities, in whose complaints were taken seriously. It is important to note that this persistence did not require conscious intent. Many physicians genuinely believed they were acting objectively. That belief was part of the problem. Objectivity, when built on biased foundations, reproduces harm while denying responsibility. The enslaved individuals who endured 19th century experimentation never had the opportunity to contest the narratives written about them. Their descendants inherited those narratives without consent. The gap between lived experience and recorded knowledge widened over time. What makes this history particularly difficult is its quietness. There are no singular villains to isolate, no single institution to dismantle. The harm is distributed, cumulative, and deeply woven into professional culture. To confront it would require medicine to look backward without defensiveness, to ask not only what was discovered, but at what cost and to whom. It would require acknowledging that some knowledge was extracted through domination, not collaboration. Such acknowledgement remains rare. When it occurs, it is often framed as symbolic rather than structural. Memorials may be proposed, apologies issued. But the underlying assumptions about pain, resilience, and credibility are slower to change. The enslaved bodies that once filled anatomy theaters are gone. The experiments have ended. Yet the intellectual residue remains, shaping how suffering is interpreted today. This is not a story with a clear boundary between past and present. It is a continuum. The 19th century did not conclude and hand off a resolved legacy. It passed forward an unfinished moral account. At this point in the narrative, the question is no longer what happened. That much is documented, even if imperfectly. The question is what it means to carry this knowledge forward without naming its origins. The story presses onward, not toward resolution, but toward recognition of how deeply the redefinition of pain has shaped medical authority itself. We pause here, where history and consequence overlap, and where the silence becomes most instructive. Silence, when sustained long enough, begins to resemble consensus. By the time the 20th century moved into its middle decades, the foundations laid during slavery were rarely visible, yet they remained structurally present. Medical education emphasized innovation, specialization, and efficiency. Little attention was given to the moral origins of earlier knowledge. The profession taught itself to look forward, not back. Pain assessment tools became more formalized, but they still relied on interpretation. Numerical scales were introduced, yet their application depended on belief. Who was believed to be in pain? Who was believed to exaggerate? Who was believed to endure? These judgments were made quickly, often unconsciously, shaped by generations of inherited assumption. Research studies conducted during this period continued to show disparities in treatment, though they were framed as statistical anomalies rather than ethical warnings. When black patients reported higher pain levels, the discrepancy was often attributed to psychological factors, stress, anxiety, lifestyle. Rarely was the historical construction of pain considered relevant. The legacy of experimentation without consent had another consequence. It normalized distance. Physicians were trained to observe rather than to listen, to record symptoms rather than experiences. This distance had once been necessary to perform repeated procedures on unwilling subjects. Later, it became professional detachment. Detachment, however, is not neutral. It privileges those whose expressions align with expectation, those whose language, demeanor, and appearance fit the physician's internal model of a credible patient. Others are left to negotiate their suffering within a system already predisposed to doubt them. The moral horror of the earlier era lay in its explicit violence. The moral complexity of the later era lies in its invisibility. No chains, no forced restraint. Only skepticism, delay, and dismissal, delivered calmly, professionally, without overt malice. Medical institutions rarely trace these patterns backward. When disparities were acknowledged, solutions focused on training and awareness, not historical accountability. Cultural competence courses addressed surface behaviors. They did not interrogate why certain bodies had been labeled resilient in the first place. The absence of historical framing allowed myths to persist in modified form. The belief that black patients were less sensitive to pain faded from textbooks, but survived in practice as an unspoken assumption. It appeared in lower rates of analgesic prescription, in shorter consultations, in the tendency to attribute pain to non-organic causes. These patterns were reinforced by data generated within the same biased system. If pain was undertreated, outcomes worsened. If outcomes worsened, this was used to justify further skepticism. Evidence built upon evidence, each layer obscuring the original distortion. The enslaved individuals whose bodies had been used to construct these assumptions were never credited as contributors to medical knowledge. Their suffering was not framed as sacrifice. It was framed as opportunity. Even in historical retrospectives, they appeared only as context, not as agents. This erasure mattered. It allowed medicine to claim progress without reckoning, to celebrate advances without examining the conditions that made them possible, to inherit authority without inheriting responsibility. The professional culture that emerged prized certainty. Admitting doubt about foundational knowledge threatened that certainty. Questioning the moral legitimacy of past practices risked destabilizing present authority. Silence became the easier choice. Yet silence has consequences. It teaches each new generation what questions not to ask. It narrows the scope of ethical inquiry. It ensures that harm, once embedded, remains difficult to dislodge. For patients, the experience was cumulative. Individual encounters blended into a broader pattern. Stories circulated quietly, outside institutional channels. Warnings passed from parent to child. Hospitals were places of help, but also of risk. Pain was something to be proven, not assumed. This burden of proof fell unevenly. To be believed required composure, clarity, and persistence. Any deviation could be read as exaggeration. The legacy of earlier experimentation lingered in these expectations. Enslaved people had been observed under duress. Their expressions of pain had been scrutinized and reinterpreted. The habit of reinterpretation endured. The medical profession often described itself as evolving, and in many ways it did. Techniques improved, mortality rates fell. Yet evolution without reflection can carry forward unexamined traits. In this case, a diminished regard for certain forms of suffering. What remains most unsettling is how ordinary this became. No policy-mandated disbelief, no statute defined lesser pain. It existed instead as a shared understanding, rarely spoken, widely enacted. This is how systems outlive their origins. They shed their explicit justifications and retain their outcomes. The redefinition of pain for enslaved bodies was never formally revoked. It was simply absorbed into a broader narrative of progress. Its language softened, its logic remained. As we move further from the era of slavery, the temptation is to treat this history as distant, to assume that time alone dissolves moral residue, but time without examination only deepens sediment. The question that presses at this stage is not whether medicine has changed. It has. The question is whether it has fully confronted the conditions under which it learned to disregard certain pain. That confrontation has yet to reach a clear end. We pause again, not at a conclusion, but at the edge of one, where recognition begins but resolution remains uncertain. Recognition, when it arrives late, carries a different weight. It does not undo what has already been absorbed. It only illuminates it. In recent decades, fragments of this history have begun to surface more openly within medical discourse. Not as central narrative, but as footnotes, lectures, and acknowledgments. The language used is careful. Terms like historical context and ethical complexity soften what was once direct exploitation. Even now, the profession struggles to name the full extent of what occurred without diluting its meaning. When institutions revisit their origins, they often emphasize intentions rather than impact. Physicians of the past are described as products of their time. Their actions are framed as misguided but understandable. This framing preserves continuity. It allows modern medicine to distance itself from cruelty while retaining its benefits. Yet for those whose pain continues to be minimized, the distinction feels academic. The legacy is not theoretical. It is experienced in moments of vulnerability, when relief depends on belief. One of the most enduring effects of the redefinition of pain is how it shaped authority. Physicians were trained to trust their own assessments over patient testimony. This hierarchy was reinforced by the earlier belief that enslaved people misrepresented pain, either through exaggeration or indifference. Listening became secondary to observation. Observation, however, is shaped by expectation. When expectation is distorted, observation follows. Modern diagnostic technologies have not fully corrected this imbalance. Imaging and tests provide data, but interpretation still matters. Decisions about urgency, intervention, and follow-up remain influenced by judgment. Judgment carries history within it. Efforts to address disparities often focus on access, insurance coverage, geographic availability. These are important. But access alone does not guarantee equity if the underlying valuation of pain remains uneven. The history of experimentation on enslaved bodies reveals how deeply medicine can be shaped by the social order it inhabits. It adapted to slavery not reluctantly but efficiently. It developed theories that justified practice. Those theories outlived the system that produced them. This adaptability is often celebrated as resilience, but it can also be a form of moral accommodation. Medicine learned to function within injustice without challenging it. In doing so, it internalized aspects of that injustice. What is most difficult to confront is not the brutality of individual acts, but the calm professionalism with which they were carried out. The notes written in neat script, the lectures delivered with confidence, the sense of purpose that accompanied repeated harm. These were not aberrations. They were normalized behaviors within a respected profession. That normalization is what allowed the redefinition of pain to become durable. The enslaved, denied legal personhood, were also denied epistemic authority. They could not define what pain meant. Their experiences were filtered through others, reinterpreted to fit existing frameworks. This exclusion from knowledge production is as significant as the physical harm inflicted. Even today, whose experiences are considered valid evidence remains contested. Patient-reported outcomes are increasingly valued, yet skepticism persists unevenly. The past has not fully released its hold. To speak of this history is to confront an uncomfortable truth. Progress is not always clean. Advancement can coexist with profound moral failure. The benefits enjoyed by many may be inseparable from suffering imposed on others. This does not require rejecting medicine. It requires seeing it clearly. The story of medical experiments that redefine pain for enslaved bodies is not solely about cruelty. It is about how authority is constructed, maintained, and protected. About how knowledge can be shaped to serve power. About how silence can be institutional. As the narrative approaches the present, it does not resolve into apology or redemption. Those gestures, while meaningful, cannot account for the depth of what was absorbed. The redefinition of pain altered not just practice but perception. What remains is a question rather than a conclusion. How does a profession built partly on coerced suffering learn to hear pain without filters? How does it separate inherited assumption from observed reality? These questions do not yield immediate answers. They require sustained attention, humility, and willingness to unsettle comfortable narratives. We arrive at another pause here, where the weight of history presses against the present and where the cost of silence becomes most apparent. Attention, when sustained, begins to change the shape of silence. It does not erase it, but it alters how it is heard. Within medicine, there have been gradual efforts to re-examine the past with greater honesty. Archives are reopened. Names once reduced to initials are recovered where possible. Some institutions acknowledge that their early successes were inseparable from exploitation. These moments are restrained, often cautious, but they represent a shift from complete omission. Yet acknowledgement alone does not dismantle inheritance. The habits formed over generations do not dissolve when named. They require reorientation, and reorientation is slow. The redefinition of pain during slavery created a template for authority that privileged distance over empathy. That template influenced how physicians were taught to see themselves, as interpreters rather than listeners, as arbiters rather than witnesses. Changing this orientation challenges the very identity of professional expertise. For some, this challenge feels destabilizing. Medicine relies on confidence. Questioning foundational assumptions can feel like undermining trust. But trust built on partial truth carries its own instability. It fractures under scrutiny. The enslaved individuals subjected to experimentation were never afforded the dignity of uncertainty. Their pain was treated as known, measurable, predictable. That certainty served the needs of those in power. It reduced moral friction. It allowed repetition. In contrast, acknowledging uncertainty requires restraint. It requires admitting that pain cannot be fully known from the outside, that it demands attention rather than interpretation. This represents a fundamental shift from the logic of 19th century experimentation. The consequences of failing to make this shift are visible in modern disparities. When pain is undertreated, suffering extends beyond the physical. It erodes trust. It discourages care-seeking. It reinforces cycles of neglect that appear self-perpetuating. These outcomes are often discussed in technical terms: metrics, outcomes, compliance. Rarely are they traced back to the historical moment when pain itself was reclassified to serve a system of domination. That moment did not announce itself. It unfolded through routine decisions, through case notes, through lectures, through silence. Its power lay in its banality. Understanding this history requires resisting the urge to isolate it as an anomaly. It was not an aberration. It was a reflection of a society that ranked human value and allowed its institutions to mirror that ranking. Medicine did not invent slavery, but it adapted to it. It rationalized it. It benefited from it. In doing so, it allowed the moral logic of slavery to shape scientific understanding. This adaptation had long-term consequences for how suffering is recognized. Pain became something to be evaluated rather than believed, something to be managed rather than acknowledged. This approach can be useful in controlled settings. It becomes harmful when applied unevenly. The enslaved were denied the opportunity to contest their treatment. Their descendants inherited a system already predisposed to doubt them. This inheritance is not symbolic. It manifests in outcomes that can be measured, even if their origins are rarely named. The story does not offer a clear turning point where harm ends and repair begins. History rarely does. Instead, it offers a series of moments where different choices might have been made, where listening might have replaced assumption, where restraint might have replaced ambition. Those moments passed quietly. Their absence shaped what followed. As we move toward the closing stretch of this narrative, the focus narrows again, not to individuals, but to the enduring question of responsibility. Responsibility not only for what was done, but for what was learned, preserved, and passed forward without critique. The redefinition of pain was a decision, even if it was not framed as one. It reflected values. It served interests. It carried consequences. What remains unresolved is how to reckon with knowledge produced under coercion, whether it can be disentangled from its origins, whether acknowledging harm is enough, or whether deeper transformation is required. These questions resist closure. They linger, much like the history itself. We pause here, close to the end, but not yet within it, where reflection deepens and the absence of easy resolution becomes part of the truth. Reckoning, when it is postponed long enough, becomes generational. It is inherited rather than resolved. The medical knowledge shaped by slavery was not archived separately, labeled, and set aside. It was integrated. Techniques refined through coerced suffering became standard practice. Observations drawn from bodies without consent became reference points. Over time, the origins blurred, leaving only conclusions behind. This blurring made moral accountability difficult. When no single practitioner could be pointed to, responsibility dispersed. The system appeared self-correcting, progressive, even benevolent, yet its foundations remained uneven. In this way, the redefinition of pain functioned as a quiet inheritance. It did not require active belief to persist. It survived through habit, through expectation, through patterns of response that felt intuitive to those trained within them. When physicians today are taught to assess pain, they are given tools, scales, protocols, algorithms. But tools do not operate independently. They are guided by interpretation. Interpretation, in turn, is shaped by culture and history. The enslaved were excluded from shaping that culture. Their pain informed practice but did not inform ethics. This imbalance is central to understanding why the legacy endures. In the 19th century, experimentation without consent was justified as necessity. In later eras, disparity without reflection was justified as inevitability. Both rely on the same underlying logic, that some suffering is expected, and therefore less urgent. Challenging this logic requires more than reform. It requires a shift in how authority understands itself, from certainty to humility, from distance to attentiveness. Such shifts are slow because they unsettle hierarchy. Listening to pain without filtering it through expectation redistributes power. It grants authority to the one who suffers. For a profession long accustomed to defining suffering on its own terms, this represents a profound change. The enslaved never had that authority. Their bodies were sites of instruction, not voices of insight. Their pain was observed, but never believed on its own terms. This history complicates the narrative of medical heroism. It does not negate genuine advances. It contextualizes them. It insists that progress be understood alongside its costs. For viewers confronting this account, discomfort is inevitable. The instinct may be to locate the story safely in the past, to reassure oneself that such practices belong to another era. But the persistence of disparity challenges that comfort. The redefinition of pain did not end when slavery ended. It changed form. It became less visible, more diffuse, harder to confront directly. But its effects remain measurable. This is not a story of unchanging cruelty. It is a story of incomplete transformation, of a profession that moved forward technologically while carrying unresolved moral weight. As the narrative draws nearer to its close, it resists offering a solution. Solutions imply closure. This history does not grant that. What it offers instead is a lens, a way of seeing how power shapes knowledge, and how knowledge shapes care, how silence can be as instructive as speech. The enslaved whose bodies were used to redefine pain are largely unnamed. Their stories survive only in fragments, yet their impact is vast. It reaches forward through generations, shaping practice in ways that are still being uncovered. To tell this story is not to accuse every practitioner. It is to illuminate a structure, to make visible what has long been treated as neutral. We arrive now at a point of stillness. The facts have been laid out, the patterns traced. What remains is reflection. Whether this reflection leads to transformation is not for history to decide. History can only reveal. We pause here, at the threshold of conclusion, where the weight of the past presses most clearly against the present. At this threshold, the past does not recede. It leans forward. The history of medical experiments that redefined pain for enslaved bodies forces an uncomfortable recognition that knowledge can be both true in its results and corrupted in its origins. This tension has never been fully resolved. Instead, it has been managed, softened, and often avoided. Avoidance takes many forms. It appears as emphasis on innovation without lineage, as celebration without attribution, as ethics taught as a modern invention rather than a response to past harm. In these omissions, the enslaved remain present only as absence. The structure that allowed their suffering to be repurposed as data depended on more than cruelty. It depended on credibility, on whose voice was allowed to define reality. Pain in the system was not simply a sensation, it was a claim, and claims require recognition. By denying enslaved people the authority to define their pain, medicine preserved its own authority. That exchange was rarely acknowledged, yet it shaped professional culture profoundly. It taught generations of practitioners that interpretation outweighed testimony. This lesson did not vanish with time. It embedded itself in training, in institutional norms, in the quiet confidence with which judgments are made. Even now, when practitioners strive to be fair, the inherited framework influences how fairness is enacted. The discomfort this produces is not incidental, it is the point. Discomfort signals that the narrative has reached beyond abstraction and into responsibility, not guilt for actions long past, but responsibility for understanding how those actions continue to shape the present. The enslaved were never granted the benefit of ambiguity. Their pain was declared understood. That declaration justified repetition. Today, ambiguity is often where care begins, but ambiguity must be applied evenly to be ethical. When it is reserved for some and denied to others, it becomes another form of hierarchy. This history also challenges the idea that progress naturally corrects injustice. Progress can refine technique while leaving underlying values untouched. Without deliberate examination, improvement in method can coexist with persistence in bias. The medical profession often measures itself by outcomes, survival rates, recovery times. Yet some outcomes are harder to quantify. Trust, dignity, the assurance that one's suffering will be taken seriously. These are shaped by history as much as by policy. The enslaved individuals whose bodies were used in experimentation did not leave memoirs. They did not publish rebuttals. Their resistance, when it occurred, was often recorded as pathology rather than protest. This misinterpretation is itself a form of violence, one that transforms agency into defect. When we look back, it is tempting to search for moments of rupture, for the point at which medicine turned away from exploitation and toward ethics. But such moments are rare. Change occurred incrementally, unevenly, often without explicit acknowledgement of what was being left behind. As a result, the moral ledger remains open. The redefinition of pain was not simply an error to be corrected. It was a strategy that served power. Correcting it requires more than updated guidelines. It requires confronting how authority has been exercised, and at whose expense. This confrontation is ongoing. It does not belong solely to historians or physicians. It belongs to anyone who benefits from a system shaped by unacknowledged suffering. The past does not ask for absolution. It asks for attention. We stand now very near the end of this account, where the narrative tightens and the space for reflection widens. What follows is not a revelation, but a quiet reckoning. Attention, once sustained this long, alters how endings are approached. It makes finality feel premature. What this history ultimately reveals is not a single moral failure, but a pattern of accommodation. Medicine accommodated slavery. It accommodated hierarchy. It accommodated the idea that suffering could be ranked, managed, and ignored depending on who bore it. These accommodations were efficient, they were rewarded, and because they worked, they were rarely questioned. The redefinition of pain was never announced as policy. It emerged as practice. It became embedded through repetition, reinforced by authority, and protected by silence. That is why it proved so durable. It did not depend on ideology alone. It depended on routine. Routine as a way of dulling ethical awareness. What begins as extraordinary becomes ordinary. What is repeated without consequence becomes invisible. The physicians who conducted experiments on enslaved bodies did not all see themselves as cruel. Many saw themselves as diligent, curious, even benevolent. That self-perception was enabled by a system that never required them to reckon with the full humanity of those they studied. This is where the deepest unease lies, not in overt malice, but in ordinary professionalism aligned with injustice. The enslaved were positioned as problems to be solved rather than people to be heard. Their bodies became sites of instruction, their pain a variable to be controlled. Once this orientation took hold, it shaped how medicine understood its own purpose. Healing was pursued, but not universally. Knowledge was advanced, but selectively. Ethics evolved, but unevenly. The cost of this selectivity did not remain confined to the past. It traveled forward in habits of mind, in expectations about who exaggerates, who endures, who needs intervention, who can wait. Even when these expectations are consciously rejected, they can persist at the level of instinct. They influence tone. They influence urgency. They influence whose pain interrupts and whose pain is managed quietly. The history of medical experimentation on enslaved bodies therefore resists being categorized as merely historical. It is better understood as formative. It shaped the conditions under which modern medicine learned to see, to listen, and to decide. This does not mean that every medical encounter today is governed by this legacy. It means that the legacy exists, whether acknowledged or not, and that it exerts pressure unless actively examined. Examination, however, is uncomfortable. It destabilizes narratives of progress. It complicates pride in achievement. It asks institutions to consider not only what they have accomplished, but what they have normalized. The enslaved individuals at the center of this history never had the opportunity to demand such examination. Their suffering was absorbed into the record without their consent, then abstracted until it no longer resembled lived experience. Pain became data. Data became doctrine. Doctrine, once established, is difficult to undo. As we remain here just short of conclusion, the story narrows to a single enduring tension: knowledge versus accountability, advancement versus acknowledgement, silence versus responsibility. There is no final image that resolves this tension, no closing gesture that restores balance. The history does not offer that relief. What it offers instead is clarity. Clarity about how systems learn, about how power shapes perception, about how easily suffering can be reinterpreted when those who suffer are denied authority. We remain at this point deliberately, not because there is nothing more to say, but because what remains cannot be rushed. The end, when it comes, must be entered carefully. Carefully, then. If there is a lesson that emerges most starkly from this history, it is how easily moral harm can be absorbed into professional routine. The physicians who worked on enslaved bodies did not act in secrecy. Their work was discussed, published, and taught. The absence was not visibility, but challenge. No structure existed that required them to stop and ask whether what they were learning should be learned at all. That absence shaped medicine's relationship to power. Authority flowed in one direction. Those who held knowledge defined reality. Those who were subjected to it had no recognized capacity to object. Pain, under these conditions, became something to be interpreted rather than acknowledged. This orientation proved remarkably adaptable. When slavery ended, the same habits of interpretation found new justifications. Scientific language replaced legal ownership. Statistical reasoning replaced overt domination. But the underlying asymmetry remained. It is tempting to imagine that ethical standards once articulated correct the past. In reality, they often operate forward-facing only. They govern what may be done now without fully addressing what was done then, or how its consequences persist. Ethics without historical grounding can become procedural rather than moral. The experiments conducted on enslaved bodies were rarely framed as violations in their own time. They were framed as opportunities. Opportunities to learn, to refine technique, to build reputation. That framing matters because it reveals how institutions decide what counts as progress. Progress, in this context, was defined by accumulation of knowledge, not by the conditions under which that knowledge was obtained. This definition allowed medicine to advance while leaving harm unexamined. It also allowed the beneficiaries of that advancement to remain distant from its costs. Distance is a recurring theme. Distance between physician and subject. Distance between past and present. Distance between outcome and origin. Each layer of distance made the legacy easier to carry without discomfort. Yet distance does not erase connection, it only obscures it. The redefinition of pain for enslaved bodies created a precedent. It demonstrated that suffering could be discounted if doing so served institutional goals. That precedent did not require explicit endorsement to persist. It required only that no one insist on its removal. In moments where medicine has been forced to confront its past, the response has often been measured. Apologies are carefully worded. Memorials are symbolic. These gestures acknowledge harm without fully engaging with how deeply it shaped practice. They mark awareness, but not transformation. Transformation would require more than recognition. It would require medicine to accept that some of its foundational assumptions were not neutral discoveries, but adaptive responses to injustice. That realization challenges the narrative of inevitable progress for those who endure pain today and feel unheard. This history provides context, but not consolation. Context does not lessen suffering. It explains why it is repeated. The enslaved individuals whose bodies were used to redefine pain never consented to their role in shaping medical knowledge. Their involvement was coerced, their suffering reframed as utility. That injustice cannot be undone, but its continued influence can be confronted. Confrontation, however, demands patience. It requires sitting with ambiguity rather than rushing to closure. It requires acknowledging that some harm cannot be neatly resolved. As we approach the final stretch of this account, the tone necessarily slows, not because there is nothing left to say, but because what remains resists compression. The story has traced how pain was redefined, how that redefinition was normalized, and how its effects endured. What remains is to consider what it means to know this. Knowledge in this sense is not neutral. It carries obligation. Once the origins of an assumption are revealed, continuing to act as if they do not matter becomes a choice. The enslaved were denied choice. They were denied voice. They were denied recognition. The least history can do is refuse to deny these things again through silence. We stand now at the final threshold. The next movement must be a conclusion, if one is to come at all. At this threshold, conclusion no longer means resolution. It means acknowledgement without escape. The history of medical experiments that redefined pain for enslaved bodies does not end with a reform law, a discovery, or a moral awakening. It fades instead into institutions, habits, and assumptions that continue to operate quietly. The quietness is not accidental. It is the condition that allows continuity without confrontation. Medicine prides itself on precision, on measurement, on evidence. Yet this history exposes how imprecision entered at the level of value. Pain was not measured incorrectly, it was valued differently. And once value is assigned unevenly, evidence follows that distortion. The enslaved were never granted the status of reliable narrators of their own bodies. Their testimony was filtered, corrected, or dismissed. This exclusion from epistemic authority was as consequential as any physical experiment. It ensured that suffering could be studied without being honored. That exclusion has echoes. When modern patients struggle to be believed, the interaction is often framed as interpersonal failure, poor communication, cultural misunderstanding. Rarely is it recognized as the afterimage of a system that once trained itself to distrust certain voices. What makes this legacy particularly enduring is that it aligns with efficiency. Listening takes time. Doubt slows decision-making. Belief introduces moral responsibility. Discounting pain simplifies practice. It allows systems to move faster, to prioritize throughput over presence. The experiments of the 19th century taught medicine that speed and certainty were virtues, even when built on harm. That lesson was never fully unlearned. There is a tendency when faced with such histories to seek redemption through progress narratives, to argue that improved outcomes justify earlier suffering. This logic mirrors the original justification for experimentation: future benefit, collective good, necessary cost. Yet this framing repeats the same moral calculation that allowed pain to be redefined in the first place. It treats suffering as currency. It asks who benefits, rather than who bears the burden. The enslaved bore that burden without choice. Their pain was converted into knowledge they would never fully benefit from. That imbalance remains a moral fact, regardless of subsequent advances. History cannot redistribute that burden. It can only make it visible. As this account nears its end, the silence that once protected these practices becomes less defensible. Naming what occurred does not indict every practitioner who followed. It indicts a structure that rewarded detachment and called it objectivity. Objectivity, when stripped of context, can become indifference. The experiments described here were often meticulous, detailed, methodical. Their horror lies not in chaos, but in order, in the calm certainty that suffering could be categorized and dismissed. That certainty has consequences. It shapes how institutions respond to pain today, how quickly they intervene, how seriously they listen, how much proof they require before acting. The enslaved were required to prove pain beyond endurance. Even then, proof was often insufficient. The moral weight of this history does not demand despair. It demands vigilance. It demands that medicine and those who depend on it remain aware of how easily power can masquerade as knowledge. We arrive now at a point where continuation becomes choice. The narrative has reached the edge where it can either close quietly or remain open as a question carried forward. If this is to be the final part, the ending must be entered deliberately. The weight of history is not easily shaken. Each successive generation of practitioners inherited assumptions as quietly as they inherited techniques. Observation became interpretation. Interpretation became judgment. Judgment, when unchecked, shaped care in ways that were invisible to those performing it. The enslaved bodies that had been used as instruments of knowledge were long gone, but their imposed characteristics, stoicism, resilience, endurance, remained embedded in the logic of practice. Institutions rarely documented the limits of their authority. Clinical guidelines emerged, protocols solidified, yet the original moral compromise was neither acknowledged nor addressed. Pain could be measured, categorized, treated, but whose pain was given full credence depended on a silent hierarchy, one rooted in slavery and justified by science. Medical students learned to value precision and efficiency. They learned to trust instruments, charts, and textbooks, but they rarely learned to interrogate the origins of the knowledge those tools contained. The authority of the physician was rarely questioned, nor the legitimacy of the observations recorded by those who had once experimented on the enslaved. What was taught as neutrality was built upon bias. What was taught as expertise was built upon exploitation. This is the quiet horror of legacy, not the violence of a single act, but the normalization of an entire approach to knowledge and care. When practice becomes routine, ethical compromise can endure without notice. When suffering is filtered through expectation, empathy is subordinated to authority. The enslaved had no say in defining their own pain, yet the echo of that exclusion persists, even as medicine evolved, incorporating anesthesia, antisepsis, and modern ethics. The foundational assumptions about whose pain counted persisted subtly. They shaped prescription patterns, response times, and the credibility afforded to patient testimony. The hierarchy of suffering was no longer enforced by chains, but by authority, habit, and unspoken expectation. The silence surrounding these practices is as instructive as the records themselves. Names vanish, case notes obscure, yet patterns endure. Authority teaches itself through repetition. Observers learn to trust what they see and disregard what they cannot reconcile with expectation. Those who survived the experiments lived on in these lessons even if their stories remained untold. Each decision about care, what to treat, how urgently, with what intensity, carries the residue of that past. The logic persists quietly, hidden in protocol, invisible to those who follow it without reflection. The redefinition of pain did not end with emancipation. It evolved, it adapted, it became subtle, and it remains embedded even as practitioners strive for equity and compassion. We remain here, still within the unfolding narrative, confronting the weight of this inheritance. It is not a story with closure yet. It is a story of consequences, carried forward quietly, shaping perception, shaping authority, shaping care. The patterns established in the 19th century infiltrated more than procedure. They shaped perception itself. Physicians were taught to interpret expressions, reactions, and resistance according to what the system expected. Stoicism was evidence of resilience. Crying was evidence of weakness. Endurance became a measure not of the individual but of a category. Observation was no longer neutral. It was a test, performed silently, against the assumptions handed down through decades of authority unchallenged. The enslaved were never permitted to speak for themselves. Their pain was filtered, reframed, and reduced to something that could be recorded without moral disruption. The repetition of these recordings taught a new generation that this was the way bodies should be understood, that some expressions of suffering required attention, while others did not. The lesson was absorbed quietly, embedded in charts, lectures, and surgical technique. Even after emancipation, when enslaved individuals became patients with formal legal rights, the legacy remained. Distrust of testimony, skepticism of experience, and uneven allocation of care continued. The knowledge gained from experimentation did not vanish. It evolved into a culture of interpretation rather than belief. Physicians relied on what could be seen and measured, often discounting what was reported. The hierarchy of credibility persisted. Hospitals, clinics, and classrooms became the modern theaters of that legacy. The bodies of the enslaved were no longer present, yet the methods developed upon them shaped expectations for the living. Pain was still a variable to be evaluated, measured, and compared, rather than a truth to be acknowledged. The system had learned to incorporate suffering without granting it authority. When disparities in treatment appeared, they were often explained away. Cultural difference, miscommunication, psychological factors. Rarely was the historical source of these biases considered. The shadow of 19th century experimentation cast its influence silently, unquestioned, shaping every judgment that relied on observation over testimony. Yet there were moments of quiet resistance. Some physicians and patients recognized the distortion. They pressed for care, for recognition, for the acknowledgement that experience mattered. These interventions were fragile, uneven, and frequently marginalized. They were exceptions, not the rule. Still, they remind us that knowledge is not fixed, that authority can be challenged, and that systems, however entrenched, are not immutable. The redefinition of pain, once imposed, became durable not because of any single act, but because it was normalized. It was absorbed into routine. It was reinforced by training, codified in textbooks, and maintained through expectation. To undo it requires more than policy or ethics codes. It requires conscious attention, reflection, and willingness to disrupt inherited assumptions. This is the moral weight that carries forward. It is not spectacular. It does not announce itself. It is the quiet pressure that shapes how care is delivered, how testimony is received, and how suffering is recognized or dismissed. The enslaved were denied authority over their own bodies, yet their experience continues to demand attention, even as it remains mediated through the lens of history. The cumulative effect is subtle but profound. A patient may encounter skepticism. A practitioner may hesitate. Treatment may be delayed or diminished. Each instance may seem ordinary, even mundane, but each is a trace of the long shadow cast by experiments conducted under coercion. What was once explicit violence has become structural, embedded in expectations and assumptions. We remain here, tracing the contours of influence, aware that each observation, each decision, carries echoes of a system that learned to interpret suffering selectively. This is not a story of individuals alone, nor of isolated cruelty. It is the story of authority, of knowledge, and of moral compromise extended over generations. The influence of this history is not confined to extraordinary cases. It seeps into the ordinary rhythms of care. Decisions that seem procedural are in fact moral choices, shaped by patterns established long before the present. Whose pain is trusted, whose distress is minimized, whose suffering is believed. These are not neutral judgments. They are echoes of a past in which authority determined whose body was worthy of recognition. Even as anesthesia, antiseptics, and modern interventions transform surgical practice, the underlying assumptions about who endured, who exaggerated, and who required intervention remain subtly embedded. Medicine could advance technologically while remaining morally compromised. Precision and cruelty became compatible. Efficiency and dismissal coexisted quietly, reinforced by training and tradition. The enslaved were denied epistemic authority. They were treated as instruments of observation, rather than as subjects with insight into their own experience. That denial was institutionalized, and the legacy persists in ways that are difficult to name. Evidence, once recorded, carries with it assumptions that outlive the individuals who generated it. Observation becomes doctrine. Doctrine becomes expectation. Expectation shapes practice. Modern disparities in pain treatment, in triage, in prescription, reflect this inheritance. They are not the same as 19th century experimentation, but they are its descendants. The system learned to interpret bodies according to an uneven moral logic, and that logic endures, often unconsciously. Efforts to address these disparities, through education, oversight, and policy have value, but they cannot erase history. They may correct behavior, but they cannot remove the assumptions embedded in perception. Authority, once conditioned to discount certain experiences, does not relinquish that conditioning easily. Listening, acknowledging, and believing require deliberate ongoing effort. What is most disquieting is the calm professionalism with which the original experiments were conducted. The horror lay not in chaos or cruelty, but in order, method, and purpose. The notes were meticulous. Procedures were repeated. Outcomes were recorded. Knowledge was produced. And yet at every stage, the humanity of those studied was systematically erased. That erasure is its own legacy. It teaches the subsequent generations that authority need not account for suffering that does not align with expectation. It trains the mind to trust measurement over testimony, to prioritize certainty over empathy. It shapes culture more deeply than any single law, lecture, or policy ever could. We close, slowly, deliberately, with the quiet moral weight of what has been traced. The medical experiments that redefined pain for enslaved bodies were acts of authority imposed with calm precision. They were recorded in orderly notes, discussed in lectures, and incorporated into the growing body of knowledge that would define professional medicine. The horror was not spectacle, but order, not chaos, but method, not momentary cruelty, but a systemic approach to human suffering. Pain was not merely observed, it was interpreted, categorized, and given value according to the assumptions of those in power. Some bodies were considered resilient, some expendable, and all were stripped of authority over their own experience. The enslaved, whose suffering became the foundation of these lessons, were denied voice, denied consent, denied recognition. Their cries, resistance, and despair were translated into data, abstracted into doctrine. That absence is as telling as any record. It reminds us that knowledge is never neutral, that authority shapes what is believed, and that silence can be as consequential as speech. Even after slavery ended, the logic persisted. Disparities in pain treatment, skepticism toward patient testimony, and uneven care are not anomalies. They are echoes of a system that once measured suffering selectively. What was learned under coercion became embedded in expectation. Observation became interpretation, and interpretation became authority. The lessons of the past were absorbed silently, quietly shaping the present. Recognition of this legacy does not offer comfort. It does not tidy history or neatly resolve moral questions. It reveals that progress in technique, in medicine, and in outcomes can coexist with persistent injustice. It asks us to consider that every assessment of suffering, every judgment about who endures and who demands attention, carries the weight of inheritance. Authority, when unexamined, may perpetuate harm even in the absence of intent. Yet recognition is necessary. To name the history is to acknowledge that what was once coerced, hidden, and normalized continues to resonate. The enslaved bodies that shaped medical knowledge did so without choice, without consent, without acknowledgement. Their suffering was translated into power, a power that quietly continues to inform practice. To see this truth is to accept responsibility, not only for history, but for the structures it left behind. And so the story ends not with closure, but with reflection. The moral weight does not lift. It lingers in procedure, in expectation, in every moment where pain is interpreted and believed or discounted. It asks of U.S. vigilance, humility, and moral attention. Listening, in this context, is itself an ethical act. Belief is itself a form of justice. The past is never fully past. It persists in the logic we inherit, in the authority we exercise, and in the recognition we choose to grant. The experiments, the pain, the erased voices, they remain, quietly, as both a warning and a call that knowledge built on coercion cannot be separated from responsibility, and that true care demands the courage to see clearly, to listen fully, and to reckon with what has been carried forward. In that reckoning, there is no simple resolution, only the steady, patient work of acknowledgement and the quiet moral choice to never again allow authority to redefine suffering without consent.